Hi, I'm Amy Reyes. In this week's News Roundup from Rheumatology Network, we begin by highlighting 2 reports on osteoporosis. In one, doctors reporting in JAMA say that osteoporosis screening may be necessary for younger postmenopausal women. We published a Q&A with Dr. Caroline Galeotti of UCLA, who discusses the need to conduct osteoporosis screening in this population. And we featured a discussion with Dr. Suzanne Jondeber of Johns Hopkins University. She explains that managing vitamin D levels may not be as straightforward as it would seem. There are factors that should be considered that are not often communicated to patients. We posted an audio version of our discussion on rheumatologynetwork.com. And this week, we highlight 2 reports on COVID-19. In one, researchers writing in the Annals of Rheumatic Diseases report that high doses of methylprednisolone may successfully resolve COVID-19 associated cytokine storm syndrome in most treated patients. You can learn more about those findings online at rheumatologynetwork.com. And in today's one-on-one interview, we feature a discussion with 2 physicians from the University of Paris. They recently described in Nature Reviews Rheumatology pediatric cases of COVID-19 that were associated with the development of pediatric inflammatory multisystemic syndrome, or PIMS. Children who developed PIMS exhibited signs of the vasculitis syndrome, Kawasaki. The condition eventually resolved itself in most patients. And while the pandemic is under control in Paris, cases are still rising in most US states that may begin to see vasculitis symptoms like those of children described in this report. Welcome to Rheumatology Network. Pricing your findings first.
Yes. So in France, we saw at the end of April and in May, patients who presented with features of Kawasaki disease. At the beginning, we thought that it was Kawasaki disease, but we observed distinct features of Kawasaki disease in these patients. So they were older and they had myocarditis that is not very common in Kawasaki disease. So we saw distinct features. So it was called pediatric inflammatory multisystemic syndrome, and it mimics Kawasaki disease, but for us, that's not Kawasaki disease.
Mm-hmm. So it's called pediatric inflammatory multisystem syndrome, or PIMS yes. For short.
Yes.
And it's different from Kawasaki's disease. Is that correct?
Yes, because Kawasaki disease is a vasculitis, and it occurs in children older than they are 5 years old or under 5 years old. So we saw patients around 10 years and sometimes more. So that was very different. And Kawasaki disease is more frequent in Asian countries, for example. And we saw patients with Afro-Caribbean descent in PIMS. So it is different. And the patients didn't have the coronary artery dilatation that we can see in Kawasaki disease, and they had myocarditis, but not dilatation, not a lot. So there was difference, and we can see that they had abdominal pain. Sometimes some patients had to have surgery. It was a mistake, but it was different than with Kawasaki disease.
Mm-hmm.
But
so, how is it different? Can you describe one of these PIMS cases?
Yes. So the patients with this inflammatory syndrome had features like conjunctivitis. They had sometimes the cutaneous rash. They had a lot of fever and a big inflammatory syndrome. a very big inflammatory syndrome with abdominal pain, sometimes with vomiting and sometimes diarrhea. And they had sometimes heart failure. That's why maybe half of the patients had to go to intensive care unit to be treated. But it was not like with the adults and with COVID-19 disease. It was not like that. There was no pulmonary symptoms, and the patients stayed sometimes 1 week in the intensive care unit, sometimes less, and after that they were better, and they were treated with the same treatment of Kawasaki disease because they had some common features. So we decided to treat them like Kawasaki disease with intravenous immunoglobulin. And sometimes, maybe for half of the patients, we have to do another treatment after IVIG. Sometimes it was not sufficient.
Yeah. And what were the ages of these patients?
The age, it was, the median age was 10. And sometimes we had patients with 15, 16, who were 16 years old. But it was not reported in adults. So it was children.
Okay, I see. And I read in the article how it is not uncommon to have an infectious disease, a viral, I think it was it said viral disease, and lead to the development of something like this, whether it's in pediatric patients or adults. Is that correct? Did I understand that correctly?
The virus, I think, was the trigger of the disease, but it was a post-infectious disease because it occurs around 1 month after the spike of COVID-19 in France. You see the spike of COVID-19, it was in the middle of March, and we saw the PIMS in the middle of April, one month later.
Compared to adults, the children were least affected by COVID. Hardly 1%, 2%, and also clinical symptoms are not severe or critical. Children, those who are affected with PIMS, they had contact with the family members who had got this disease. These patients had mild COVID symptoms, but nevertheless, the appearance of the PIMS before and the time between the COVID exposure and the development of PIMS was up to 7 weeks. It was quite a big the time gap compared to other autoimmune diseases we can expect following an infectious bout.
I see. And what were the outcomes then?
Yes, it was good. So in France, it was reported maybe PIMS in 200 patients. Only one patient died of that. And the other stayed around 2 weeks at the hospital, sometimes 1 week in the intensive care unit with sometimes drugs for the heart, and treatment with immunoglobulin, sometimes with biotherapy. And after that, they were fine. And sometimes it was very fast. And so now they are very well and without, for the moment, sequela. So they don't have sequela of the myocarditis, and they don't have dilatation in the coronary artery. So they are fine. I think they will be fine because now, 2 or 3 months later, they are fine. So,
So in tracking their blood tests of their normal levels, there's nothing out of the usual to indicate that this would have long-term ramifications or effects on their health.
Mm-hmm.
Mhm.
Yes, we will see. We have to check the heart and the artery to be sure that. But now I think it will be fine, because in Kawasaki disease, we know that the patients can have a dilatation or aneurysms in the artery, but after 3 months, it's fine. So maybe it will be the same thing, but we don't know all the things, and we don't know very well the pathophysiology of the disease. So we will see.
Right.
Yes, at the beginning it was it's difficult, because they have a fever, and sometimes a lot of fever.
Right.
So they are tired, and they were sometimes very painful, and so that's different from Kawasaki disease. Sometimes they were very, very painful, and so at the beginning it's difficult, because we have to transfer them to the intensive care unit, so that's difficult for the patients. But after that, with treatment, and after 1-2 patients, we know what was the disease. It was the diagnosis was made more rapidly. It was we knew that, and so we took care of the patients better. So at the beginning, it's very difficult, but after that, after 1 week, they were better. So
yeah,
and what is yes, it was very difficult at the beginning, but after that, and with a child, I think the recuperation is more fast.
Yeah.
It's more easy for children, and
But there
Right.
are a couple of points more important in this case, COVID-associated Kawasaki-like disease. The first aspect is there is a general shift in the susceptibility group. As Caroline said, normally it's less than 5 years. This time is mostly seen in more than 10 years old, even in adolescence. That is the key factor why it has shifted. This more important to know. Although there are many susceptible genes have been identified, why in particular some children it causes disease? That is question mark. That has to be explored. Another aspect is normally Asian children are more susceptible for Kawasaki disease. In this case, African origin or even Hispanic origin in or Latin origin in United States, they are more prone for this disease. So whether it's a particular variant form which is causing the disease, which we don't know, and whether it's molecular mimicry by which virus directly causes this Kawasaki-like disease, we don't know. Whether it is act as a trigger for some other environmental trigger to cause disease. So many unknowns, and being a new virus, we are learning so many new things which we are not aware of at all in the past. So we don't know whether this virus cause some unknown or entities in the long term. So we have to be vigilant. That's true.
Right. So I imagine that you'll continue to watch this and study the developments. This is brand new. Like you said, it's nothing that you've seen before in patients of this age. Well, I wanted to thank you both for talking with us today. I have not written about this yet, so I was eager to talk with you and get this on record and just report these findings and these observations that you've had at the hospital. But otherwise, how are things in Paris in terms of COVID-19? Is it beginning to subside there?
It has been subsiding
Yeah.
last we are not seeing any what we understood, because we have we have a French National Research Agency funded project, ongoing project. So we were getting the patients earlier from the hospitals, but now they say the intensive care units are quite empty in Paris region.
Wow.
Yeah.
Mm-hmm.
But I think there are some clusters in the Northeast and also in the Mediterranean region. So it's not all gone or all done or dusted.
Okay. Well, thank you again. I appreciate your time. I wish you both the very best there. And what we